Okay, so I'm going to move on to fibroids slash polyps. This is probably, a lot of people ask me, I have nurse practitioners actually do my HSGs, and they take like 30 million pictures. You really only need three pictures, that's it. You need the initial fill of the uterus right here, and you could see something's going on. That's probably the most important picture. My nurse practitioners, they go in, they're so focused on the tubes, and I'm like, where's the uterine pictures? And they're like, oh, you wanted those? And I'm like, yes, I do, on the initial fill, because there's something going on there. And uterine pathology can be picked up. I mean, I know we have ultrasounds and stuff, and you're going to pick up a uterine issue with that. You could see now it's gone. There was a fibroid there, I'm telling you that, but there was a fibroid, now you can't see it because it's opacified, right? So the initial insulation of the dye is actually very important. And I know some of you use cook cannulas and stuff, but I like traction on the uterus because you've seen these oblique uteruses, sideways, forwards, backwards. It gives a distorted view of the cavity. It's really, I understand it's painful. No one wants to put a tenaculum. I use hurricane, I use lidocaine, I use everything I possibly can to alleviate the pain, but it's really, really important to straighten this uterus out, okay, because you can have distortion. So I'm a real big proponent of using a tenaculum and putting traction so I get proper view, and you can't really get that. I guess you could fill the bladder up, or fill the balloon up big enough inside the uterus so you could pull on it, but to me that's almost as much discomfort with a 1-2 cc balloon in there. So I like traction. You could see there what's going on. You could see, and I'm telling you it's a fibroid, but you could see, but also you should be thinking about adenomyosis, and I'll have a discussion about that, but you could see the infiltration. So people freak out about this. It's okay. Obviously stop, but you could see the internal iliacs going, and then the tubes are right here, but it's hard after that occurs. So fibroid, adenomyosis should be in your differential. And just speak to the fibroids. We all know the classifications of it. I don't know if Paya's here, but I've not heard about the 3 fibroid rule about fertility in terms of affecting fertility. I think there's a size criteria, like 6 centimeters, where we tend to operate on fibroids for fertility issues. But it's really location, location, location. So these fibroids, type 0, 1s, 2s, and right here, intramurals, if it's greater than 6 centimeters, I tend to operate, but I leave these alone. 5, 6, 7s, 4s, I leave those alone. And MRI is going to clarify things. Size does not matter, in my opinion, in my humble opinion, but the location, but unless the location is significant. And you can see here that it's all based on symptomatology for me. If this woman does not have symptoms and she has a fibroid of a certain size and there's no pressure symptoms, there's no bad bleeding, I tend to leave those fibroids alone. But it's very rare to have a large fibroid that has no symptoms. So you have to get a good history. And once you get a good history from that woman, they start thinking, wow, going through 6 pads, missing work, having accidents, I mean, that's significant. And for some reason, you women think that's what you're supposed to deal with. I mean, that's absurd, right? So you really need to educate the woman in terms of, I could make this a lot better, and that's when a myomectomy might be indicated. You just introduce that concept. When do I operate? I just suggested that. It's when it's symptomatic. Age is a factor, actually, when someone's trying to get pregnant. If they're older, they obviously have other issues that are preventing them from getting pregnant. So a fibroid, unless they're symptomatic, I tend to leave alone because they got bigger issues, and they should do IVF or IUI or some type of active. And doing a myomectomy in an older woman who's asymptomatic, I don't think you're doing that woman any favors. But if they're younger, then absolutely there could be benefits to removing that fibroid depending on where they're located. So it's a combination of age, location, size, it's not just one size fits all in terms of the indication to remove fibroid. Submucosal fibroids obviously need to be removed. Multiple miscarriages, if there's a fibroid there and they've had a loss, a 17, 18, very traumatic loss, I'll go ahead and remove that fibroid. But when do I operate on fibroids? When you're trying to get pregnant with IVF, this is my criteria. I get asked this a lot. It's all about deviation of the endometrial cavity. And I know that's kind of subjective, but that's when I operate. And if they do have symptomatology, I'm going to definitely operate. There is a number of embryos that I kind of classically, there's no data on this, but this is how I practice. If there are 2 or more euploid embryos without implantation and there's a fibroid there, I'm going to probably discuss with that patient about its removal.